Good afternoon. This is the final module in the C3IFT training course, and this module is going to cover pediatrics. So children are a unique group of patients. They have special needs and problems that actually will differ from an adult, and sometimes that requires a different amount of equipment and tools that are designed specifically for the smaller bodies. At one time, a long time ago, the training was focused on the theory that children were nothing more than just small adults, and the difference in that couldn't be more poignant. It's time for change. There is a system called the Emergency Medical Services for Children, and it was specifically designed to ensure that there was continuing education courses in pediatrics and to expand the curriculum that the paramedics go through to include specific pediatric training. So today we're going to look at how to identify the anatomical and physiological differences with children, be familiar with the growth and development and different medical transport and trauma transport concerns. And we also want to be familiar with general management considerations, understand what the special health care needs are for children that are dependent upon technology to survive, and realize when we've gotten in over our heads and what we can't actually handle. So just as a quick reminder, neonate is considered birth to 1 month, and during that time frame they will lose approximately 10% of their body weight within the first 10 days. It's really important for us to keep them warm because they haven't developed those mechanisms on the descending nervous system tract side to ensure that they have the ability to shiver and stay warm. So we want to make sure we care for those patients appropriately. Infants are 1 month to 12 months, and you want to keep them warm and comfortable, whereas with toddlers, they're moving into the 1 to 3 years of age. This is the time when they're able to kind of care for themselves to a specific point because they've got the gross motor development that is occurring, and the language development begins during this time frame. Our preschool ages from 3 to 5, our school age is 6 to 12, and then adolescence is 13 to 18. And in puberty typically hits with males around age 13 and 11 for females, but it's really specific to the child. Children are nasal breathers when it comes to their airway, particularly the infants. They are the nasal breathers. The larynx is more anterior, it's higher. The cricoid ring is the narrowest point in the airway, and the airway is typically cone-shaped or conically shaped. The trachea is smaller, it's less rigid. As we grow and we get taller, it tends to straighten out and get strong and rigid, and the epiglottis is also more floppy in the children. In terms of the chest wall and the lungs, the cartilage offers less protection because the cartilage hasn't turned to solid bone yet. The muscles are more immature, they fatigue a lot quicker, and the lung tissue is more frail. The mediastinum is a little bit more mobile than what it is in the adult, and the chest wall is thinner in children, so it's very easy to miss a pneumothorax or misplace an intubation due to the breath sounds and not being able to identify the location of the breath sounds. For children, their output in the cardiac system is dependent upon the cardiac rate, the heart rate. So cardiovascular output is based on their heart rate. Bradycardia is a lot higher. It's because of the vagal response in the body. It's easier to trigger the vagus response and drop the heart rate. So we also need to be very careful with that. And the pediatric patients can maintain their blood pressure for a longer period of time than an adult. But general management concerns, each condition is going to require a certain type of management, but there is a specifications. We're going to look at those general managements and how we're going to deal with those patients that we encounter in the interfacility realm. Because most children do not have cardiovascular issues at birth unless there's a genetic abnormality, the airway is of the utmost importance. Single most frequent complication is accidental extubation in those that are on transfers. So we want to make sure that the ET tube is properly secured and that we have lateral restraints to the head. One study done said that if the patient was secured to a backboard with lateral restraints to the head, that helped to maintain airway positioning and cause less issues. But we want to monitor and continue sedatives as ordered, and we want to look at the vascular access because it's a big concern. There's lots of points though that we can utilize, and we want to maintain both venous and intraosseous access points and make sure that the fluid boluses is no more than 20 cc's per kilo unless it's a newborn. If it's a newborn, we're looking at 10 cc's per kilo. As I mentioned previously, children have a big issue in temperature regulation and maintaining their core body temp, so we have to be very aware not to let them get cold. The other thing too is that they become hypoglycemic, and as a result of that, D25 is actually the preferred fluid for continuous infusion. The degree of stability that the patient demonstrates after you complete your assessment is going to help you determine or anticipate future needs. But you need to gather the following information and continue monitoring and report to the receiving facility. You want to ensure that they have a current, that their mental status has not changed, so you want to assess that frequently. And you want to be very aware of both the pulse ox but also capnography and end-tidal CO2. You want to look at ventilator settings, perfusion and assessment, and as needed, don't forget that 12 lead and EKG interpretation. When you're taking that patient, you want to also look at the lab values in that patient's chart. Make sure you look at the blood chemistry and any x-rays, and make sure that you take any and all copies of these reports and leave them at the receiving facility. During that detailed exam, you want to look at all body systems and regions. So you want to go to head to toe in the older child, but toe to head in the younger children. You want to look in younger children for hydration by seeing if they're producing tears. You want to check the skin turgor, look at the color, and also consider urinary output. The goal of the C3 paramedic is not to diagnose or plan the initial course of treatment for your patient, but rather to continue the treatments that are actually prescribed by the sending or the transferring physician. The cardiac arrest, the #1 cause of cardiac arrest in our pediatric patients is respiratory arrest. So that's why it's so important for us to focus our attention on the respiratory system. So when we look at pulmonary emergencies, some of the things to consider is the cough. Do they have a croup or a barking type cough? You may also encounter issues with epiglottitis or asthma, bronchiolitis. Maybe they have a foreign body airway obstruction or pneumonia. Those are very common. Be very aware of dehydration or hypoperfusion syndromes, congenital heart disease in those rare occasions. And with the neurological disorders, we look at seizures. This is the #1 cause for children under 5. The #1 cause is febrile, or they're fever related. But otherwise you're looking at meningitis or encephalitis. And meningitis, remember, can be primarily bacterial or viral. And then the encephalitis is also of concern. You won't be able to tell the difference in the pre-hospital setting between encephalitis and meningitis, but you will be able to get the results from the sending facility. So make sure that you maintain any body substance isolations with all medical emergencies regardless. Also, children can, their regulation of their blood sugar levels can alter, particularly if they're in a medical condition where they have medical concerns, which is why we're transporting them in the first place. So you want to make sure that you monitor the blood glucose while en route, because they can shift and alter periodically. So the other thing to remember is if you see a change in the mental status of your child, make sure you do a blood glucose check, particularly if you have no explainable cause for that change in the mental status. Now, trauma is a very common thing for children, and sending them to the trauma centers. The margin of error in both time and interventions can be extremely narrow, so you want to be very aware and very prepared for decompensation. So you want to anticipate any problems from the start. You want to do a very clear and continual assessment and correct any and all airway problems that you find. How we approach a pediatric patient that has experienced trauma is going to vary based on their age. The foremost consideration is the patient's emotional and physiological development. So care is also going to involve other family members. They're going to want to demand information from you, express their fears, and you want to also be aware that they may give or refuse treatment or transport. Once you arrive at the facility, get the report from the person that is placed in charge of the patient and gather the information, including those lab values, the x-rays as we mentioned before, but also if they're on a ventilator, what those vent settings are and what the transfer orders are. Some other things is how long, the length of time of the injury, what has happened. You want to get the background on it, input and output, the treatment that's required versus what's been received up to this point. And you can always, fall back on the pediatric assessment triangle that the PEP program has taught us and look at any vital functions. It's not intended that the C3IFT paramedic be able to treat all aspects of pediatric trauma. 90% of all traumatic events involve one of three, if not all, the body systems in children. This includes the head, the chest, and the abdomen. The treatment is much the same as adults, but your injury patterns are very different. For instance, with head trauma, this is considered the leading cause of death in a pediatric patient. You want to use the pediatric Glasgow Coma Scale in the evaluation, and you can see the listing here. With chest injuries, they fall second to the head injury. Pneumothorax and hemothorax is very common. The flail chest is uncommon because of the flexibility of the cartilage. And chest tube, if the chest tube is in place, you want to make sure that you constantly monitor both the respirations and that chest tube during transport. And with our abdominal injuries, the blunt trauma is usually going to result in injuries to either the spine or the liver or the spleen was what I meant. And post-trauma surgery has reduced some due to the advanced imaging technologies that are out there. But the trauma to the liver and the spleen occurs because it sits, in the adult it's protected underneath the rib cage, but in children the rib cage is shortened and not quite as extensive, so it's more exposed in the abdomen. Definitive care in the case of a pediatric trauma patient. Surgery is not needed as much. Most commonly injured organ is in fact the spleen. Your solid organs can be monitored without surgery unless the bleeding is detected. Your mortality rates are continuing to improve on our trauma patients, and children, let's face it, are amazingly resilient. But some special healthcare needs that are coming out there. There's an increase in the population of children that are technology dependent, and also you want to consider the developmental age versus chronological age. So what we're saying here is we have some differences between their development versus the chronological. And the children that are dependent upon technology can include things like home ventilators, tracheotomies, gastric feeding tubes, and shunts. And just remember to talk to the family members, because they're going to know what is baseline for their child. They're with them 24 hours a day. They're very, very keen and very aware of what's normal for their child, and also they're very good at the equipment that is kept with those children. But the big thing to remember with pediatric patients, because they are intimidating, because they're so small and they have such a long life ahead of them, never put yourself or the patient at risk. If you're not comfortable with that transport for whatever reason, don't take it. They have PICU and NICU teams, specialty teams that are out there that can handle those patients if you are not comfortable with that. And this concludes the last module of the C3IFT course. If you have any questions, please let me know. Now, understand this does not mean you can go take your state certification exam. You still have to sit for the skill examinations, and we will hold those classes, so you need to get in touch with me so that we can determine when that time frame needs to take place, because you do have to perform skills as part of this program. So if you have any questions, give me a shout. Otherwise, I'll look forward to talking to you soon. Have a great week.